morning, everybody. Let me try to... I wish I would have had put a slide like what Nancy did about Iowa, just to show us where we are, but I didn't. So I'm going to tell you a little bit more about the general scenario of my country, which is a little bit different from, I think, what I see here and what you experience here. So Italy is a country where 90% of the health system is based on public system. We don't have private insurances or private treatment, as mostly private treatment as you do have here, where we have little fundings for research in general in psychiatry and really no fundings at all in the borderline personality disorder area. Having said that, we are trying to do our best. I'm going to describe you, as you can see from the title, the implementation of a psychoeducational approach for families in two different areas. One is a community mental health center, which is called Fano Department, and the other one is a small RCT, the replication of what we did in Fano at Bologna University. Having said that, I just want to say that also one thing that is really lacking in my country is specific treatment for borderlines. Very little is done, unfortunately, for patients and even less for their families. So far, there's no public awareness, no advocacy groups. So we're really working in that direction, and I will tell you a little bit more about that at the end of the presentation. A few research findings. We all know that, generally speaking, mental illness is a family affair, and it's even more so when it comes to borderline personality disorder, considering the interpersonal nature of its characteristics. We know that families are highly impacted by the presence of a person with borderline personality disorder, and in turn, they can impact the course of the illness of the person with BPD. That's why it's very important, as we know, to include them in treatment and to help them. We know that they experience a very high level of grief, burden, depression, and distress. And it has been found that at the same level of distress that families with a BPD member experience is comparable to families with a member with PTSD or schizophrenia. Differently from schizophrenia, though, what's been shown by Perry Hoffman and others in their paper is that differently from schizophrenia, the higher level of emotional over-involvement is associated with a better clinical outcome. It's been also shown that a higher level of knowledge, though, is not associated with a better outcome, and actually it can increase the level of burden of grief, depression, and hostility towards the PBT member, meaning that it's not enough to actually make positive or meaningful changes within the family system to inform about the disorder. It's important to do much more than that. Having said that, it's very important to include families. We can also say that both the APA guidelines for treating borderline personality disorder and the more recent NICE guidelines suggest family involvement in treatment. Up to date, there are 3 family intervention programs described in the literature. One is the Gunderson Multiple Family Group here in Boston at McLean Hospital, as you all know. And the other 2 are DBT-based. One is Family Connection, NEA.BPD, by Hoffman and Frusetti, which is a family educational program. So usually, as you know, the groups are led by family members. And the other one is DBT Family Skill Training. What we did in my country, especially in our center, was actually trying to find inspiration from what is published in the literature, was shown to be effective with data. All of these studies have good data, MFG has pilot data, Family Connection has more published data about the efficacy of the treatment. It's been actually combining the two and try to see whether the models described in the literature could apply in our country, in our system, and which were possibly the differences between two different, pretty different cultural systems like America and Italy. So what we did was actually a pilot study. It was combining multiple family group, which was our major model, and integrated, multiple family group with some DBT skill training. Let me give you like a few words about multiple family group. Multiple family group is a psychoeducational program. As I said, it was developed here at McLean, initially borrowed some tools from the groups that shown to be effective for families with schizophrenia, like the ones used by McFarland, and is ideally divided in 3 different phases. An initial phase that is more didactic, a second phase that is more focused on problem solving and the use of family guidelines. The Gunderson family guidelines are 15 family guidelines, which are ideally divided in 4 sectors, which are family environment, addressing problems, problem management, and setting limits. And part of the format, is also the work on attributions. Attributions is a concept that was adapted by Fonagy's concept of mentalization, and it consists of a group of exercises that we give family members to learn what we call borderlineese, basically to help family members to gain a better understanding and a better awareness of what are the thoughts, the needs, and the fears that are behind the apparently ununderstandable behaviors of their loved ones. For doing that, we use vignettes, and we also take examples from the family members who they bring in the group. So these are the 3 major elements. What we did in our program was actually following the multiple family group structure, doing the didactic part, but even if we describe all the evidence-based treatment for BPDs, we mainly focus on DBT because we added, as I said, some parts of them, and I'll tell you a little bit more about it later, and also MBT because we use attributions, which is, as I said, adapted for concept of mentalization. To the general multiple family group structure, we added some of the DBT skill training. It's very important to tell you that none of us is a DBT therapist. Until 2 years ago, there were no possibilities in the country to get trained in DBT, and no possibilities for us to come here to get trained because there were enough people in a team speaking English enough to get trained here, except for me. So there's been a big problem for that. So we try to do our best with what we have. We have done the DBT 2-day workshop for skill training. So we try to take it from there. And we integrated the multiple family group with some validation skills, with some skills from emotional well-being, like in family connection, but we work a little bit on emotional regulation. We do some mindfulness. And also we try to select some parts of the DBT skill training manual, which is translated in Italian, to do problem management. So we do some chain analysis, some interpersonal effectiveness skills, and we also try to focus on the dialectics of acceptance and change. Having said that, we try to define this model, which is a model of 6 months, total of 12 sessions. We meet every 2 weeks for 2 hours each time. Basically, in the first hour, we focus more on the didactics. So we provide information about the etiology, the symptomatology, models of treatment, and we use mainly a booklet by John Gunderson, which is a BPD brief, which we translated into our language. Then in the second part, we focus more on family guidelines, which are something that we do every session. For 12 sessions, we always work on family guidelines, along with either attributions or some DBT skills training. Usually in the first part, like 4 to 6 sessions, we work only on family guidelines and attributions. In the next 6 sessions, we work mainly on DBT skill training, on the parts that we integrated of the DBT skills training. The second hour is more focused on check-ins with families. We do some role playing. We do brainstorming about major problems or major issues shared in the group. We also give some space to feedback and support for the family members. We have one leader and one co-leader. Usually the leader is a professional and either a psychologist or a psychiatrist. Unfortunately, we don't have social workers like here in my country. And the co-leader is a certified nurse who's been attending part of the individual sessions that we did before, and she's now co-leader in the group. And what we also did is putting together a little manual, which is describing session by session what we do, and we give it to the family, and it's sort of manual that guides both the leader and co-leader and the family members. We try to assess the efficacy of this model in a small pilot group, and yeah, let me tell you, we've been funded, so it was the first time that in Italy, the government actually gave some money to BPD, so it was not a lot of money, but made us very happy that somebody actually acknowledged the presence and the problems of BPDs and their families. So we did a small pilot study, 13 family members who were family members of 7 persons with borderline personality disorder. It was a naturalistic study, so we had pre, post, and 1-year follow-up measurements, and I'll tell you more about it. As I said, the treatment was MFG integrated with some DBT skill training. These are some social demographics. I wanted to point out, I would like to know what you think about it, that the mean age is pretty high, and you will see in the Bologna study it's even higher, it's 34, 35. Just to point out that usually people get to our services after a long time, after having been misdiagnosed, usually with axis 1 disorders, and mostly with either MDD or generalized anxiety disorder. And they get to the treatment much later on in life. The other reason why the mean age could be a little bit higher from what you observe here is that we try to select pretty severe patients for the study, and because the family were more overwhelmed, so we thought to give them priority to assess the group. Gender, we had 6 females in the patient group and 7 females in the family members group. It was a heterogeneous group, so we had mostly parents, but we also had 2 siblings and 1 partner. Total of, as I said, 13 patients. Which were our family outcomes: decreased family burden and improved family functioning. Let me take you quickly through the measurements, because they are Italian measurements, but because of course we had to use validated, we wanted to use validated instruments. ABC is an acronym that it doesn't really make sense in English, but anyway, A stands for help, B stands for needs, and C stands for burden, okay? So basically it's a questionnaire, it's a self-administered questionnaire assessing the help received by the help received by the families, the levels of burden, and the levels of needs. Family functioning questionnaire is again a self-reported questionnaire, and it assesses the communication skills within the family, the presence of criticism, hostility, and of positive attitude and goal-oriented behavior within the family. These are pilot study results. We know that the study is very small, so they're not big data, but just wanted to make some consideration, because we saw that the burden at T1 had a significant reduction and stayed stable at T2, which means after 1 year from T0 from baseline. Communication skills decreased significantly at T1, didn't stay stable at T2. We would expect it actually that if burden decreases, also family communication skills decrease, which happened at T1 but didn't happen at T2. Reason for that could be that among the 13 family members, we had 4 family members who underwent a very severe financial crisis. Right now in the country, there's like between 20 and 30% of unemployment rate, and so 4 of them lost their jobs, and 1 had to deal with lung cancer. So they had other big stress factors within the family that could have not kept or could have not given them the opportunity to practice more the communication skills and keep them stable within time, but it's just one speculation. Here's, I'm sorry for the bad choice of colors, but it illustrates you the 2 measurements. The first one is ABC burden. The second one is communication skills for each family member. I want to tell you that beside of the statistics, all the family members were very satisfied, and also the patients reported that they saw their family members changing, they saw their family members more engaging towards them, more actually keen to help them, to listen to them, and to be really part of the treatment team, which didn't happen before. So it's beside of data, but we think it's a very important clinical start. We later tried to replicate the pilot study in a pilot RCT. We had 18 family members this time and 15 BPD patients. As I said, it was RCT, so in the experimental branch, we had MFG, same model as I described before, and treatment as usual. A few words about treatment as usual in my country. Again, is really, I would say, no treatment as usual. It probably could give you a better idea of what we do. Okay, so means that they get a general psychiatry interview. They meet for medications. Usually it's too many medications, and that's it. And they get hospitalized every time they are in a crisis. That's why we are putting lots of effort. And I forgot to tell you that there are only a few, I think 3 BPD centers in our country. One is Fano, which I direct, coordinate, and the other 2 are private. So we're really a rare minority, and we try really to do our best. So we try to see how this could work. And as I said, same clinical model. Primary outcomes, this time we wanted to assess as a secondary outcomes the patients as well. But the primary outcome were families, and it was decreased family burden, improved social network, and treatment satisfaction. A secondary outcome was improvement in psychopathology for BPD patients. Similar assessment instruments. The first one was family problem questionnaire, which is again a question assessing burden, assessing hostility and positive attitude. We added a social network questionnaire to see whether the social network intended a social life, affective and practical support by others, including partners, could actually improve over time with the treatment, with the intervention, and the general satisfaction questionnaire about treatment team, about what they receive from us. As for patients, we use the Zanarini rating scale for borderline personality disorder. This is the flow chart of the randomization. So we had 29 referrals. 10 were excluded for not meeting criteria for this inclusion criteria for the study. 19 were enrolled, but 4 refused, and I will tell you a little bit more about that, because sometimes we had problems because patients didn't want families to be in the group without them being there. And also, as I said, in my country, there's not a culture about, I don't know, family interventions in this area. So it was a pretty new thing, and they didn't want their parents to come. Anyway, we had 15 at the end, 15 participants. Where they were randomized either to treatment as usual or MFG. Treatment as usual were 7 patients and 8 relatives. MFG were 8 patients and 10 relatives. So it's a small RCT, but we wanted to assess it. Social demographics is the same as I said before. So mean age is even higher here, 32, for the same reasons I described before. 11 females in the patients group and 9 females in the family member. Again, it's a heterogeneous group. Here we had also 1 grandmother and 1 aunt, along with partners, parents, and siblings. We just finished the study, which means really finished, like a week ago. So we don't have a data analysis yet. But what we saw is the family problem questionnaire decreased. As you can see, these are just the mean at T1, but went up again at T2. Reason for that, most of them said that they would have liked maybe more support in the second part, which means ideally would have been going towards an advocacy group, being more part of the group, more part of the community, which didn't happen. But social network increased the mean. I'm talking increase in a positive way. I cannot say statistically what happened yet, but as you can see, the experimental group had a better outcome in the social network as compared to the treatment as usual. And same happened with general satisfaction questionnaire. You will see that I think it should have been called general unsatisfaction questionnaire, because the higher the scores, the more unsatisfied the families are, okay? So it goes down, and as you can see in the multiple family group, it decreased, while in the treatment as usual, actually didn't change, but increased a little bit. But these are just raw data. Same for NEA.BPD. We still don't have the T2 data, but we had some decrease, but it's too early to say whether we really had changes in those. Which are the study limitations? The sample is pretty small, so one of our future direction would be actually to do a bigger RCT, and we're working in that direction. We have 50 family members ready to start to be enrolled in the study. Also, the absence of validated specific instruments for families with a BPD member. So some of the questions were not specific. For example, they were more focused on family members with a person with schizophrenia. So we would like to do that. Problems encountered, resistance to diagnosis. Some of the family members and still some of the patients don't accept the diagnosis of BPD. So it was very hard to have them participating in the study for this reason. For parents, for the reasons I mentioned before, we had an initial resistance to be involved in the treatment. And we had another problem, which I didn't add here, and I'm not sure it's a cultural difference, but it might be. I know you experienced that too, because I've been a part of the groups in America as well in my past, professional life, but in the last few years. But sense of guilt. You know that, I don't know if you know, but Italy is really structured about sense of guilt. We are born, religiously. I say with total respect, but because I'm Catholic, but we were born and we already know we have this sin, and it grows over time. And I'm really far away from me. I'm not making fun of my religion, but it's true. It's culturally visible. So we apologize for everything, really for everything. I was talking about Francine Franceburg about that a while ago. We really apologize about everything. And we feel guilty about everything, really totally guilty about everything. We have to work on that a lot. So when it comes to families, when you present a model, ethopathogenetic model, which is multifaceted, I hope this is the right pronunciation, it's a tough word for me to pronounce, and doesn't exclude, let's say, the sense of that families could play a role in developing the disorder, as opposed to what happened in this group for schizophrenia. sense of guilt raises so much. I think also in American family members. Can you imagine Italian family members? So we had really to work a lot on that part in explaining what we meant and in being compassionate towards them and be very empathic towards them. Another problem that could be cultural was difference in the BPD symptomatology. Sometimes, when I compare the borderlines I see here and the borderlines I see in my country, they're a little bit different. Of course, they satisfy, they meet criteria, but they do self-harm less, for example. They do have more aggression towards others and less towards self. They are less keen, and I'm talking, there's no published data, there's no published article, I'm just talking from clinical experience. They are less keen to sit in a group because, again, we're ashamed, because we feel guilty if we do less better than the other next to us, and it's really true. So they don't accept individual group therapy as much as individual therapy. We had the same problem with parents. So there are some cultural differences we are noticing. We try to make something out of that and maybe adapt a little bit, let's say, the American models to our country in the future. Sometimes we had problems about not having homogeneous groups. So sometimes we would have liked more to have a group for siblings as opposed to a group for parents and so on. And now we're thinking about having a group for sons and daughters, for offsprings of BPD mothers. So but we're pretty far away, but it could be a really future direction. In conclusion, family members of BPD seem to benefit from our intervention. In particular, they improve their functioning and social network and reporting and reduction in their burden. During our intervention, family members felt the need to launch the first Italian organization dedicated to advocacy. To me, this is one of the biggest results. And we are gonna soon join the wonderful Perry Hoffman, who's helping us, and NEA.BPD, hoping to have pretty soon NEA.BPD Italian branch. And along with that, I've done the training with Perry and Alan a few months ago, Perry, yes? And we will soon bring a family connection to Italy. We're working on the translation of the manual, so cross your fingers for us, but we'll try to do our best, even with very low instruments. I already told you future directions, just a few words. It's a long list of my Italian colleagues who are dedicating their efforts to try to change things in my country for BPDs. And you can also see as consultant John Gunderson and Mary Zanarini, and I take the occasion to publicly, deeply thank them for having been so helpful through the years in my life. Thank you very much for your attention. Thank you.
Our next speaker is Carla Sharp, who's so anxious to speak. She's following me right up here.